Thank you very much. Thank you for the introduction, and more importantly, thank you to the organizers for this very kind invitation. So when I got this invitation, of course, I was very thrilled, but at the same time, I was a little perturbed in the sense I pondered at length what lipid guidelines would be most relevant for this audience. So, we have the Indian guidelines, and then we have the European guidelines, we have the Canadian guidelines, we have the American guidelines, we have the old guidelines, there are new guidelines which are coming, there is something called the prevent equation, there is so much. So how do I synthesize all of this in 15 minutes? Or to borrow a term from this land, how do we do sabke saath, sabke vikas, okay? And this, so, this is like, I'm in Gujarat and 2 weeks before the elections, I could not resist, okay? So, no, I'm completely apolitical. Anyway, so when I pondered about this is what I thought would be the most relevant guideline for us. It's not about AHA, ACC, all of these things. Cholesterol treatment is not about moving cholesterol numbers from point A to point B. It's about this. It's about preventing sudden cardiac disease. This is a myth. There is nothing like a sudden heart attack. Nothing happens suddenly. And this is what should keep us up at night. So everything is cooking right under our nose, and of course, as you can see, also under the patient's nose. And so this also affords us tremendous opportunity to prevent cardiovascular disease. And that's what lipid lowering treatment is all about. And so we are, as I told you, so this, when I was a fellow, these are the kind of guidelines that we had to memorize. Oh, what is the LDL threshold for initiating lifestyle therapy, initiating statins, what is the goal, and so on. We have moved away from this because we know that this is not what really, we want to just save lives. And what have we moved to? We have actually moved to the other extreme where all we do is just give people statins. This is kind of supposed to be funny, supposed to be sarcastic. So when the new guidelines came out, now they're not relatively new. 10 years ago when the 2013 ACC-AHA guidelines came out, the New York Times, so they made fun of this and they said, this is what the new guidelines are. Check your pulse, and if you have pulse, take a statin. That's what all the lipid lowering guidelines are. Well, in some ways it is true, but then, the way they made it sound was this is a pharmacological conspiracy to put everybody on a drug. I don't think so. There is good reasons for doing this. You are all aware of many of these studies. So there have been tons of studies which have shown that statin therapy lowers cardiovascular risk. So these are the primary endpoints, secondary endpoints, primary prevention, secondary prevention. And as recently as a year ago, so there was this large meta-analysis of all the statin trials, and as you can see, all the relevant endpoints are all actually beneficial. CV mortality, all-cause mortality, MI, composite cardiovascular endpoints, while all the adverse effects, we do not see any increased risk. So statins save lives, they are safe, so which is why we want to give most people statins. And so as I told you, this is what, in 2013, there was a paradigm shift. So we moved away from moving cholesterol levels to giving people statins. And the guidelines actually recognize 4 major groups of patients who will benefit from statin therapy. These are mainly patients with known cardiovascular disease, people with extreme hypercholesterolemia, an LDL cholesterol greater than 190, basically people with familial hypercholesterolemia, people with diabetes, and if you don't fall into any of these 3 groups, but if you still have a high estimated cardiovascular risk, then statin should be given to them for primary prevention. By and large, this is where we are. In the next 10 minutes that I have, what I'm going to do is to give you the top 10 points of what we have done over these last 10 years since these new guidelines came out is really just hemming and hawing at the edges. I don't think much has changed in terms of the overall approach. So we give people statin, but then, we have made some small changes. So I'll try to summarize them with the top 10 points of these new ACC-AHA multi-systemic guidelines, which are kind of similar to every other guidelines, and I think which is what will save lives. Here's the most important one. The top message of all of these guidelines is this: in all individuals, emphasize heart-healthy lifestyle across the life course. People have already spoken about this, and then we have had talks on nutrition itself, so I won't belabor this point. But then we have to emphasize a good diet, limit the intake of sweet, sugar-sweetened beverages, red meat, so on, weight loss, and aerobic activity. So all of this is extremely important. So this is number 1. So before we go into drug therapy, so a heart-healthy lifestyle has to be emphasized. And when we start drug therapy, this is probably the number 2 important message is this. In all patients with established ASCVD, reduce the LDL cholesterol with high intensity statin therapy or maximally tolerated statin therapy. So this is nothing to do with what the actual cholesterol is and where you want it to be. We know that somebody with established ASCVD is at very high risk for future events, and giving them the maximally tolerated statin therapy will reduce it. So that's why we are giving it. We are not giving it to lower their cholesterol. We are giving it to prevent future heart attacks and strokes. We should use the maximally tolerated statin therapy. So that basically is like, that's what the high intensity statins are. So they would cause an LDL cholesterol of at least 50%. Greater the LDL reduction, greater is the risk reduction. So again, as you can see, there is a linear relationship between LDL lowering and event lowering. This is for primary prevention. This is for secondary prevention. So always. So if you lower the LDL cholesterol, you get lesser events. What's number 3? This is, well, again, pushing the envelope a little further. What about those people with extremely high risk? Now, what are extremely high risk? So these would be people who have had multiple ASCVD events, or they have had an ASCVD events and still have multiple high risk conditions like diabetes, hypertension, and so on. So if you have a diabetic who has already had a heart attack, then he would be very high risk. In these people, again, we don't want to use the term goal, but then we can use this, the new term now is threshold. We look at a particular threshold of LDL cholesterol when we would add non-statin therapies. And that would be the ACC-AHA says something like 70 milligrams, the Europeans say 55 milligrams, so whatever it is. So in these people who are extremely high risk, we should be even more aggressive. We put them on a high dose statin, then we add either ezetimibe, and if it is still high, then we should probably add a PCSK9 inhibitor. And this can either be monoclonal antibodies to PCSK9, or we have the small interfering RNA to the PCSK9. And now we have another newer addition, that's the oral medication, bempedoic acid. So we should consider these medications in very high risk patients. A few points about this. So I think this came out earlier in the morning. Should we do LDL cholesterol? Should we do non-HDL cholesterol or ApoB? I think we discussed about it. In people with high triglycerides, the LDL cholesterol does not convey all the message. The bad cholesterol is carried not in the LDL particle, but then in the remnant particles. So a good way of looking at that is to measure the non-HDL cholesterol, or since all of these particles have one molecule of ApoB, you can get ApoB as an integrated measure of the atherogenic index. So you could do this. And these are probably, this is the ESC guideline. So what is the goal in people with average risk? So you want the LDL cholesterol of 100, very high risk. This would be 70, very high would be 55. I'm going to gloss over this mainly because I don't think that there is any scientific basis for any of these numbers. And that's because, so this is the so-called GLEGO trial. So where they use statin plus a PCSK9 inhibitor. And what they did was they looked at the plaque regression. So they did this intravascular ultrasound. And what you can see is the decrease in the plaque volume. And this is the LDL cholesterol that was achieved. So you can see again there's a linear relationship. Yeah, so people who got an LDL cholesterol of 60, there was greater regression than in those with 70. And it goes on. So people who had an LDL cholesterol of 20, they were much better than 30. So who is to say that you should stop at 55 or at 70 or at 40 or at 30 or at 20? So we never see this graph plateauing. And as we already spoke in the morning, we don't know whether it is dangerous. At least there is no indication of it being dangerous. So even though these so-called guidelines, they do it mainly because you can't obviously get everybody down to 20, 30, then everybody is on every single drug. So that would open the floodgates. But keep this in the back of your mind. So we are not really shooting for any particular LDL cholesterol. The point is lower the cholesterol, lesser the event rates. Now, what about newer medications we have for this? So besides statins, so of course we have all of this PCSK9. We don't have time to go into the physiology of this, but then this is really very interesting how these PCSK9, very powerful drugs, we have these monoclonal antibodies. I'm sure this is already available in India, alirocumab and evolocumab. They cause about a 50-60% additional LDL reduction added to statin therapy. And now we have this newest one, the small interfering RNA. I think there was a talk that was scheduled but didn't happen or something, but you really should. This is very, very interesting. So like it has this interesting mechanism where you have this double-stranded RNA that goes and it silences the messenger RNA for the PCSK9 for up to 6 months. So you just give one shot of this, and for 6 months you have an LDL cholesterol that is lower by 50%. So this is a very new thing that we have, and very effective, very convenient. And the other new thing that we have is this oral medication called bempedoic acid. I assume it is either already available or will probably soon be available. The main advantage of this, it works very similar to a statin. So, statins lower cholesterol synthesis in the liver by inhibiting HMG-CoA reductase. In the same pathway, up here is something called ACL, which is ATP citrate lyase, and that's what this inhibits. So it's like a statin, but the only difference is it needs to be activated. It's a prodrug. And this activating enzyme is only present in the liver but not in the muscle. So it's a liver-specific statin. So in people who have the muscle adverse effects, this would be a very good drug. And we have good data to show that this is the clear outcome study which came out about a year ago. So it lowers LDL cholesterol, okay, moderately, about 20% or so. But what it really does very well is it lowers the HSCRP, C-reactive protein, which as we know is a very good marker of vascular inflammation and predicts events over and beyond cholesterol levels. And it reduces that by up to 30%. And look what it translates into. So every endpoint that they saw, 4-point MACE, 3-point MACE, whatever, so this medication actually lowers the risk. So it saves lives. So we should consider bempedoic acid also as an addition to statin therapy in the appropriate patients. All right, moving on to the next point. Now the next point is in people is very similar. Okay, so we spoke about people who already have established ASCVD. The other kind of people who will very closely approach this risk are patients with familial hypercholesterolemia. These are people with extremely high cholesterol, LDL cholesterol above 190, and we should do the same thing. We should put them all on high intensity statin therapy and then add one of these non-statins, ezetimibe or bempedoic acid or PCSK9 inhibitors. Let's move on to people with, this would be diabetes. Now, there was a time when we considered everybody with diabetes to have a cardiovascular risk equivalent, but nowadays we don't think that is true. That's probably true only in people with long-standing diabetes. But nonetheless, everybody with diabetes we know is at high risk, and so we should be aggressive. So what the guidelines recommend is, if you have somebody with diabetes who is of the age of 40 to 75 and does not have low cholesterol, that is to say his LDL cholesterol is not below 70, then they should be on a moderate intensity statin therapy at least. If they are at high risk, then we should probably be putting them on a higher intensity statin therapy. Now, and of course, if they're, and so on, okay, give them ezetimibe, give them PCSK9, all of these things. But we should be having everybody with diabetes who are age 40 to 75 probably on at least a moderate intensity statin therapy. Now, what about the other age groups, like people who are, say, older than 75? Now, it's certainly if they're already on a statin, we should continue that. But then should we initiate statins in somebody over 75? Well, we don't really have good data where only people over 75 have been included in the study. So we don't know. I guess we'll have to discuss with the patients. If you have a frail old 75, I would not initiate statin therapy. But if somebody is young, a young 75, then I do think it would be reasonable to do that. More importantly, what about the younger folks? Unfortunately, we have had this discussion again from morning that there is so much young people who are developing diabetes. Should they all also be on statins? So what the guidelines recommend is those below 40, between 20 to 39, if they have a long duration of diabetes, like type 1 diabetes over 20 years or type 2 diabetes over 10 years, or if they already have albuminuria, retinopathy, neuropathy, like other end organ damage, then it is reasonable to consider adding statin therapy already. All right, now let's actually move on to, so we have actually done the three major things: people with established ASCVD, people with very high cholesterol, and people with diabetes. I think these were relatively straightforward. Nobody had any issue with this. The issue is with primary prevention. People who don't have this, 40 to 75, who are evaluated for primary ASCVD prevention, what should we do? The first thing that they say is, talk to the patient, okay? So this is not somewhere where we see everybody and just write a prescription for statin. We need to discuss with them, statins are not really they're not going to completely eliminate heart disease. They're only going to lower the risk, and they will come with a cost, financial cost, side effects, and so on. So we'll have to discuss all of these things, get the patient's preference before we make a diagnosis, before we make a decision to give them statin therapy. So they emphasize that, And then how do we actually go about? So this is where we calculate the risk. So we have all of these risk engines. As I told you, there is going to be new risk engines that will be released very soon. It's called the prevent equation. There are 8 different points that they are looking at, and we'll talk about that some other time. So you calculate the risk, and as of now, if you have a risk greater than a 10-year estimated risk greater than 7.5%, it would be reasonable to consider starting moderate intensity statin therapy. Now, sometimes it's not all that clear. Patient may want, may not want, so he's kind of dilly-dallying. Those are the times when we look at so-called risk-enhancing factors. What are these risk-enhancing factors? These are the ones. A family history of premature ASCVD, people who have got cholesterol levels above 160, metabolic syndrome, CKD, other inflammatory conditions like rheumatoid arthritis, premature menopause, preeclampsia, well, unfortunately people like us, and some lipid biomarkers, an elevated C-reactive protein, an ApoB greater than 130, elevated lipoprotein little a. If you have the presence of any of these, then even in people with borderline or intermediate risk, it makes sense to start statin therapy for primary prevention. Now, finally, if you're still not sure what to do, then you can consider doing this coronary artery calcium score. So that's when you would do CAC score. You do not do it in people whom you know are very low risk or very high risk. So it's this intermediate gray zone, that's where you would do a CAC score. And as somebody pointed out in the morning, you don't do it in people who are already on therapy. In fact, it's misleading. So it will increase the calcium score while decreasing the plaque volume. So in the appropriate patient, when you do this, if the CAC score is 0, it is reasonable to withhold statin therapy and reassess in 5 to 10 years. Now always remember, a CAC score of 0 does not mean the risk is 0. It just means the risk is less than 5%. It's usually about 1 to 2%. That's what they saw in the MESA. So it would be reasonable. If I have somebody who is high risk, I don't even bother. I just simply give them a statin. And if the CAC score, once you get a CAC score that is not 0, then it's probably reasonable to initiate statin therapy. And they have these numbers, 1 to 99 or greater than 100 or greater than the 75th percentile. I don't think there is very great science to this. I mean, 0 is probably, it is 0 or non-zero. That is what that matters. And again, not recommended in high-risk individuals. This would be people with diabetes, people who smoke, people who have genetic dyslipidemia, like family history of premature ASCVD. I've seen a lot of diabetics getting a CAC score. I think that's dangerous. Soft plaques do not show up, and we will be misled by having a 0 CAC score in them. Finally, so we need to assess adherence and other things to the LDL cholesterol lowering therapy, and therefore it is recommended that we get a repeat lipid measurement 4 to 12 weeks after the statin initiation or dose adjustment, and repeated every 3 to 12 months as needed. So we don't really need to keep doing a lipid profile every 3 months. So once we know that somebody is on stable doses, effective doses, then I think it's fine. Statins don't cause liver damage. They don't need every 3-month liver profile. And we certainly don't need to check CK levels unless they have any symptoms. So that's the quick and dirty that I had. If you have any questions, I'll be glad to.
Thank you, sir.